Thank you all for attending the in-person course. Now we'll apply the principles, heuristics, and methods that were previously outlined to some specific patient populations. Key concepts. Principles. They are foundational truths or anchoring premises. For example, progressive overload, or Wolff's Law. Heuristics are simple rules of thumb or mental shortcuts. They make our lives a lot easier. For example, using a patient's pain as an indicator for exercise intensity or repetitions, how many sessions per week or number of weekly sets or reps per body movement per part, and methods. Resistance training, RPE, reps in reserve, percentage of training, strategies for increasing percentage of load volume or duration, a lot of options here. Special considerations for runners. Some buckets to fill here are load management, tissue resilience, acceleration and deceleration, shoes, and technique. Load management includes a variety of training factors. It should not just be thought of as how much distance an individual is running. Factors such as acute to chronic workload ratio, total volume per week, and total volume per day can be important depending on the goals and needs of the runner and will impact discharge planning considerations and exercise program development and recommendations. Standalone principle running is that it's repetitive, therefore will undoubtedly place stress on certain structures more than others, regardless of volume, intensity, duration, shoe wear, and more. Therefore, strength training should always be recommended. Delphi consensus on bone stress injuries in running athletes rated risk factors of developing a bone stress injury based on consensus and lack of weight training was as high as 60%. Signs of femur bone stress injury in runners are atraumatic hip and groin pain that isn't position related and that worsens with repetitive impact and improves with rest. A general heuristic here is in the diagnosis of a hip flexor or quad strain in a distance runner, it should always be considered as a proximal femur BSI until proven otherwise. If you are suspicious of a BSI, prescribe strict non-weight bearing orders and refer to an ortho for MRI. Additionally, it's also important to consider less objective variables such as tissue resilience. Resilience in this context is implying that even though something hurts, the individual is probably pushing through it. Further considerations are, will they eventually develop an adaptation for this? Or is this something that will fester and cascade in other issues? For example, plantar fasciitis that causes someone to modify their stride length and leads to an Achilles tendonitis and an increased hamstring tightness, but resolves with stretching, versus a stress fracture that continues to nag regardless of distance and leads to pain with walking or standing. Acceleration, deceleration. Runners are runners, and we tend to all assume there are two categories, the casual 5Kers and the marathoners. But really, there's a wide range. So getting a background on your patient's why for running is valuable, as acceleration and deceleration are two very different stressors. Every step taken in running is an acceleration and a deceleration at the same time. Therefore, exercises to promote tissue elasticity and tendon stiffness should always be included in an exercise program. Shoes. Our recommendation is keep this conversation brief. Suggest whatever's comfortable for the individual, and we're not shoe salesmen. So if it ain't broke and you can't see their toe popping through, don't fix it. Send them to someone who will take an objective measurement. Technique. Heel strike versus forefoot strike. Heuristics for both are as follows. Running style is usually contingent on shoe wear, and then which running sport, but generally speaking, forefoot runners will have an increased emphasis on maximal Achilles and posterior tib rigidity and plantar fascia stiffness due to high peak forces and increased time under tension. Exercises like isometric split squats should be prioritized to increase tendon thickness and tissue capacity. Conversely, generally speaking, heel strikers should emphasize fluidity throughout the grade cycle, prioritizing plantar fascia flexibility and compliancy, and Achilles and/or posterior tib elasticity and stiffness to improve stretch reflex response. The takeaways here are address the low-hanging fruit. In other words, shoe wear, running style, and running demands. If they're not blatantly a problem, ignore them. If not, monitoring of athletes running and recommendations on resistance training should be top priority. According to Honing et al. 2024, resistance training loads do not need to be specific like high loads and low reps or any secret ratio. They should just generally exceed 75% of an individual's run rep max up to 90%. In order to stimulate sufficient tissue adaptations such as thickening of tendons, ligaments, and cartilage, as well as stimulate increased bone density in order to reduce the risk of an injury, such as a BSI and tendonitis.
The next group that we'll discuss are our fitness athletes. So right now we're going to kind of break that down into Olympic weightlifting, powerlifting, and CrossFit athletes. Typically, these are going to be people that are exercising for exercise or exercising for sport. Some jokes might be exercise racing or fitness racing. Along with these three categories, you can kind of consider people who are doing F45, Barry's Boot Camp, Orange Theory, training for a High Rocks event, or basically anybody that's doing some sort of group exercise class. They'll all kind of fall into these categories. But Olympic weightlifting, powerlifting, and CrossFit tend to be pretty much all-encompassing, so we're going to talk about those. Unlike some of our other patients, this group of patients, they're already exercising, and building a well-rounded program is not necessary. They're already likely working with a coach or following a program. Our role here is not necessarily to train them in their sport, but to support their transition from injury or rehab back into the gym. It's likely that right as soon as we see them, they'll be itching to get back into the gym and back to training before we've completed rehab and definitely before full recovery has been achieved. It's important to acknowledge this early in the plan of care and to provide safe recommendations for exercise. Otherwise, the patients will be left to their own devices and increase the risk of causing some kind of harm or delaying recovery. In the event that it's completely contraindicated that they go to the gym, be frank about this and provide a timeline of when different things will be introduced. Hopefully, this will keep them engaged and adherent with your recommendations. Using PT sessions to try out different movement and loading patterns that may be appropriate for them to get back to is also a great way to keep them engaged and allow for some programming outside of PT sessions. That way they can continue with a consistent training routine, and that will make transition from PT even easier. It's important to have a basic understanding of the demands and specific movements associated with each sport, because that will aid in your discussion. It will give you ways to regress activities that they plan to get back to and give them safe alternatives to the things that they're not ready to start yet. In most cases, they're not going to be back to 100% before returning to the gym. I'm probably not going to have a power lifter all the way up to their 700-pound back squat before we discharge them, but we do want to get them on a solid program getting ready to get back to that point. This population will mostly be providing programs that support the graded return of their desired training, primarily focused on accessory movements and appropriate modifications to their current programs, and also improving their decision-making abilities to allow for progression and to maximize self-efficacy. If you've listened this far and you are going to take the post-presentation quiz, our special word of the day is lemon. First of the fitness athletes, we'll talk about powerlifting. Powerlifting specifically is the squat, the bench, and deadlift, or SBD. If you know, you know. The goal of the sport is to lift as much as possible for 1 rep in each lift to achieve a total score of pounds. Each movement has its own unique set of considerations, and there are a lot of dials we can turn to modify training. We've talked about dials in the in-person course, training volume, and other variables. It will be important to identify normal training volume and routine so that we have a clear picture of the patient's goals and we can set some expectations progressing through rehab and from rehab to modified training. In the context of returning from an injury or surgery, tissue healing time is paramount. Prioritizing other forms of training, like increasing cardiorespiratory endurance, will likely be at the forefront of their initial recovery. Given the demands of the sport, the patient will not be at pre-injury strength upon discharge from PT. Like, we won't discharge someone that's already able to back squat 700 pounds. They'll probably just be on their way. We should ensure that the tissue can tolerate loading and the patient demonstrates a good understanding of hurt versus harm to allow for self-efficacy upon transition to training. In the context of returning from an overuse injury, maximizing training stress is paramount. This can be considered as walking a tightrope, modifying only those things that need modification while maintaining volume and intensity of unaffected movements. Set the expectation that there will likely be some overshooting during this period and reiterate hurt versus harm and strategies to manage acute symptom flare-ups. Modify accessory lifts to maximize potential for adaptation while limiting excessive or repetitive strain at the involved tissue, such as using dumbbells versus a barbell to introduce bench press, because the dumbbell immediately limits the loading potential while creating sufficient challenge to drive adaptation, and allows for a more free movement pattern versus the rigid positioning of the barbell. We talked about some different regressions and different movement variabilities in the first part of this course. Provide some mobility activities that were successful during formal PT should range of motion deficits persist, or should patient demonstrate an increased tolerance of training with use of these strategies. Consideration of mobility is important to achieve full range of motion for each lift. Using partial range of motion exercises may be a good strategy earlier in recovery, but moving through full range of motion should be stressed as soon as appropriate. As we talked about earlier, modifying training volume and frequency, such as decreasing weekly volume or increasing intra and inter-session rest periods, will reduce demands at tissue and can increase tolerance of training. Use of volume load can also be a useful metric to monitor training stress as session intensity increases. Volume load is simply the number of reps times the load. So if I do 10 squats at 100 pounds, that's a 1,000 pound volume load. You can use a simple rule of thumb that volume load of any one movement pattern should not be increased by greater than 10 to 15% per week. We want to get back to training as soon as possible, but that training doesn't need to be unmodified. Building strength takes time, and doing too much too fast increases the likelihood of developing an overuse injury versus achieving desired outcomes faster. The next sport that I will review is Olympic weightlifting. The two, or technically three, main lifts within the sport of Olympic weightlifting are the snatch, clean, and jerk. The clean and jerk are performed together during the sport. The goal of this sport is to also lift as much as possible for one repetition of the snatch and clean and jerk to achieve a total weight lifted. These lifts are all highly skilled, requiring a combination of strength, power, mobility, and coordination, and hours of practice to master technique. Our role in these athletes will primarily be providing appropriate accessory exercise to support the return to main lifts, including restoring deadlift strength, squat strength, front rack positioning, and overhead strength, restoring increased rates of force production by incorporating activities like intensive plyometrics, and restoring mobility, including strength in end range positions. A final note on both powerlifting and Olympic weightlifting. These are both weight-constrained sports, which means participants compete in different weight classes. It may be beneficial to have a discussion regarding energy balance, specifically consuming sufficient calories with a primary focus on protein of greater than 0.7 grams per pound of body weight daily, to support muscle growth and limiting risk of developing relative energy deficiency in sport, or RED-S. In the presence of decreased training volume and intensity, some patients may be inclined to restrict caloric intake to maintain their desired weight. This can contribute to delayed healing and poor recovery in response to training. Increased fatigue and decreased performance can be early signs of RED-S. For the last of our fitness athletes, we'll talk about CrossFit. CrossFit has a reputation for high rates of injury after a study in 2013 claimed that 73% of participants experienced injuries. It was later determined that the methodology of the study was flawed. It was not peer-reviewed, and it was conducted by an institution that was historically critical of CrossFit. The study was then retracted that same year. Since that time, multiple studies have identified that the injury incidence rate in CrossFit is comparable to other forms of recreational fitness activities. All that to say, if your patient wants to resume participation in CrossFit, don't discourage them. Instead, facilitate a safe return. A systematic review completed in 2025 identified limiting or conflicting evidence that various non-modifiable and modifiable risk factors were associated with increased risk of injury. But increased duration of participation was identified as protective factor for injury. In a systematic review completed in 2022, shoulder and lower back pain were identified as self-reported injuries with the highest prevalence. We can use this information to guide our recommendations for appropriate modifications for patients with shoulder and lower back injuries. CrossFit combines elements of weightlifting or weight training, gymnastics, which is moving your body through space, and monostructural movements, which are repetitive cyclic activities that can be completed for a long period of time. We covered weightlifting and a form of monostructural movement, running, earlier in this presentation. Considerations for gymnastics include the demands of supporting body weight in both a hanging and inverted or handstand position, which both require high levels of tissue resilience at end ranges of shoulder flexion. Achieving full range of motion and ability to produce and maintain force in these ranges will be a prerequisite to resuming higher skill gymnastics movements, such as kipping pull-ups or handstand push-ups. Another cornerstone of gymnastics movements is the ability to create and maintain shapes, specifically the hollow and arch positions. Due to scalability, low intensity, and limited joint excursion, training the arch and hollow positions can likely be prescribed early in rehab or recovery, which will reduce the effects of detraining and allow this athlete to feel like they're getting back to the sport that they enjoy. Now to talk about some of the specific movements in CrossFit. They're not necessarily unique, as you can see the 9 foundational movements: the shoulder press, push jerk, deadlift, clean, high pull, air squat, front squat, overhead squat, all transition into other movements that may be more complex. We covered most of the weight training considerations when discussing powerlifting and Olympic lifting. The 9 foundational movements listed are defined by CrossFit in the context of their unique training methodology, but can all be identified as a portion of either a clean, jerk, or snatch. These movements can be useful in prescribing regressions for our Olympic weightlifting athletes, as well as in assessing our CrossFit athletes' readiness for return to classes. By identifying faults in these movements, we can provide recommendations for appropriate accessory exercise, mobility and/or strength focused, and for appropriate modifications allowing for a return to a class setting, which is likely going to be the priority for these athletes.
Chronic diseases. Exercise has long been considered safe and effective for chronic disease management with excellent results to show. However, just because exercise is a panacea doesn't mean it can be applied equally across populations. As with all special populations, exercise and its prescription must be applied individually, considering factors such as etiology, medications, including their side effects, and acute physiological responses. Osteoporosis patients should perform load-bearing exercise that promotes weight through the bones, increasing bone mineral density, or BMD, via mechanotransduction. BMD, most improved, tends to be in the vertebrae and hips. Of note, though, most studies do not show any meaningful improvement in bone mineral density of the femoral neck, lending further credence to the importance of strength training to decrease fall risk, as risk of femoral neck fracture is high. Training programs should be of moderate intensity, defined anywhere between 65 to 80% of a 1 rep max, and low intensity, less than 65% 1 rep max, has been shown to be insufficient to stimulate meaningful osteoblastic activity. In other words, if it's not heavy, it's not heavy enough. Another key principle of prescribing discharge exercise for these individuals is the incorporation of plyometrics. In order to improve the rate of force production that's needed to carry over into improved stepping response and fall prevention reflexes. That being said, the same type of training program is not recommended for these individuals for performance of greater than 1 year due to the suspicion of a lack of stress sensitivity from the bones from their same repeated stimuli. If plyometrics are prescribed, they should be scaled to appropriate intensities and volumes in order to decrease the likelihood of bone stress. These individuals are also recommended against excessive training due to the risk of endocrine disruption, affecting estrogen production and release, further exacerbating the issue. Optimal discharge programs should include an element of close kinetic chain loading, including pushing, pulling, carrying, squatting, hinging, and lunging at moderate intensities between 65 to 80% of the 1 rep max, and have options for alternating performance at least 1 time a year in order to reduce the likelihood of decreased bone stress sensitivity. Although this might sound like muscular confusion or any of those theories from like the 90s, 2000s, it really is just saying their bone stress sensitivity will decrease with time, and we need to shake up the types of things they're doing in order to keep the sensitivity levels. Cancer. Due to the wide-ranging types, medications, and affiliated diseases/disorders that can accompany, we're going to be speaking very broadly here. When considering exercise prescription for individuals with active cancer, the primary consideration should be the individual's medical status and treatment phase, aka what medications are they on and what treatments are they receiving, such as chemotherapy, other affiliated drugs, radiation, infusions, etc. The next is safety and contraindications. Certain conditions like bone metastasis can cause increased risk of fracture, cardiotoxicity, and low blood counts. As always, but even more so, treatment should be individualized for these patients. Exercise has been widely shown to be safe for individuals with cancer. However, as the old adage goes, the dose makes the poison. So careful consideration should be taken into account for training history, current level of activity, and other relevant factors as mentioned. Lastly, diabetes. Although both are effective forms of management for diabetes, resistance training and aerobic training, resistance training should be prioritized over aerobic training. Considering type 1 versus type 2, individuals with type 1 diabetes should be monitored regularly, as mean resting blood glucose levels have been found to have a greater reduction for up to 24 hours following resistance training when compared to aerobic training. In type 1, individuals with significant muscle mass experience acute decreases in blood sugar in response to exercise and should be expected, and individuals should be cautioned to monitor their blood glucose levels regularly until they're comfortable with their resistance training program. In other words, if you have a patient with type 1 diabetes, with high muscle mass, just let them know, check their blood sugar regularly, maybe keep something nearby if they need. In type 2, similar effects will be seen due to the increased glucose transporter presence, increased insulin sensitivity, and increased lean body mass. However, these individuals tend to be generally safer to exercise independently without the need for close monitoring out of fear for acute blood sugar reductions. Next up, postoperative. When it comes to tissue healing timelines, the primary principle to consider is the inflammatory process. Generally speaking, this predictably occurs in 3 phases regardless of tissue and injury type. Inflammatory coming first, from anywhere from 0 to 7 days, proliferative second from 1 to 6 weeks, and remodeling/maturation, nomenclature is a little dependent on the tissue type, running from anywhere from 6 weeks to 2+ years. When discharge planning from the evaluation to the late stages, this should be accounted for in order to prevent excessive use of visits, overutilization of manual therapy, and to decrease the risk of patient dependence. Helpful heuristic to utilize for ligament reconstructions is the research from Yao et al. 2021 that shows roughly by 6 months, graft ligamentization occurs with collagen fibers regaining organization and vascularity improving daily, gradually returning the tissue to a similar tensile strength and tissue capacity to the native ACL, continuing for up to 4 years post-op. For the late stages of rehab, the principle of specificity should always be number 1. Exercise demand should closely and safely mirror that of the intended activity and/or sport the patient is returning to, incorporating factors such as rate of force development, rate of force absorption, time under tension, coordination demand, reaction timing, cognitive stress, and the various energy systems that supply these functions. This principle holds true in discharge exercise programs as well and shouldn't require a lot of brain space to perform. Generally speaking, if the sport is a field sport, the patient will require some degree of high rate of force production for short bursts, no significant time under tension unless they're like a football lineman, and prolonged aerobic capacity for up to 30 to 45 minutes depending on summing, and a fair to high degree of agility and/or coordination due to field type, meaning grass or turf, and rate of play. Methods that work well for discharge exercise programming for these types of individuals include supersetting activities and/or circuit or time-based activities such as Tabatas and AMRAPs, which supply mildly aerobic stimuli while allowing for high rate of force production and absorption demands, increasing anaerobic capacity for carryover with sport-specific demands like agility and coordination over long periods of time. If they're not playing a field sport or boxed-in sport where boundaries or competitors are directly opposing them do not exist, such as swimming, running, or cycling, the agility and coordination and anaerobic system demands are generally less, placing increased emphasis on time under tension from prolonged use and increased aerobic demand. Methods that work well for discharge exercise programming for these individuals include isolating moderate to heavy load training sessions for soft tissue adaptations, and separate aerobic training focusing on tissue tolerance and energy system demands. This, of course, depends entirely on the individual, length of the sport, recreational task, and should always be tailored to the patient. Consulting with the MD, one of our favorite moments as PTs in an outpatient practice, right? So consulting with the MD in this context should ideally happen along a 3-point methodical process. Number 1 is need to know. Exchange of information should occur on a need-to-know basis. Does the doctor need to know when they started running? No. Should they know their patient was supplied with an exercise program intended to return them to running marathons if they're seeing them in a week or 2? Yes. Because continuity of care is critical to long-term success, and if we continue to allow MDs to make decisions and/or provide opinions on patients on movement-based issues, we'll always remain tertiary providers. In other words, make it hard for them to say no because it was so good. Number 2, successes and failures. This is a bit anecdotal, but my method is, if it's a significant patient success, like a total turnaround story or if it's a flaming dumpster fire failure, we should really be reaching out. Touching base when it's a success gives the MD peace of mind that when they consult with the patient next, they're really just there to give a final write-off on a successful course of medical treatment, and it increases provider consistency. Failures, however, are obviously more important. I often reach out to surgeons when patients' symptoms are lingering, when it's a predictable or unclear diagnosis, suggesting they consider a second look at providing medication and/or ordering imaging. And more often than not, this has caught and prevented something that could have become much worse after discharge from what took me all of 60 seconds to write an email. Lastly, surgeon preference. We all know which surgeons are more particular than others about providing guidance, regardless of the research, expertise, and success occurring in the treatment. So simply put, if you know there's going to be an issue, reach out explaining the discharge plan and make it undeniably difficult to ignore.
Next, we're going to talk about dealing with setbacks when you're not in direct care of the patient. Setbacks are a normal part of the recovery process, and the expectation for their occurrence should be set throughout formal PT and upon discharge. Utilize your one-to-one time with the patient during their course of care to outline strategies to manage acute symptom flare-ups through the use of load management. So whether that's decreasing their training stresses via load modification or increasing rest periods or taking a short break from aggravating activities while increasing non-aggravating activities, whatever strategies that you can teach them during your time that they can then use when they are no longer in your direct care. A simple resource such as the pain and activity traffic light, which we talked about in the in-person part of this course, can increase the patient's self-efficacy in identifying their response to training and then their ability to create appropriate modifications in your absence. The next step, once the patient is no longer able to manage on their own, if they're having a setback that they are very concerned about, or they are not sure how to continue to deal with, is to communicate with the PT. Now we can start to use an avenue called remote therapeutic monitoring, which is a billable way to follow progress without in-person visits. It's different than a virtual visit or telehealth. It's specific for indirect monitoring of a patient's condition in the long term versus more of an acute visit type of situation that we would see with telehealth. The Centers for Medicare and Medicaid Services approved the use of RTM CPT codes as of 2022. So this could be a way for us to remain an active participant in the patient's transition from rehab to desired activities. In the event that you feel the patient needs further evaluation, you can utilize direct access to resume a new plan of care. A patient can see a PT without a referral in the state of Connecticut, so as long as the physical therapist refers to an appropriate licensed practitioner if upon examination or re-examination, the same condition for which the patient sought physical therapy does not demonstrate objective, measurable, or functional improvement in a period of 30 consecutive days or at the end of 6 visits, whichever is earlier. Therefore, in short, we have 30 days or 6 visits to identify a problem and manage it before we need to refer to a provider. If that condition is improving during that time and we can objectively measure it with a reeval, then we don't have to refer them back to a provider at all, and we can continue to monitor their progress. Immediate referral to a physician is indicated if any red flags, such as unexplained pain, fever, or neurological changes, are identified. If a medical condition beyond the PT scope of practice is suspected, or if a condition that requires further diagnostic imaging is suspected. Signs to increased suspicion of fracture include recent trauma, significant pain or tenderness at specific points depending on injury, swelling and bruising, deformity, inability to bear weight on the affected extremity. These are reasons why we would call a doctor and refer our patients to see someone when their problem seems to be outside of our scope of practice.
Thank you all for your attention. Next, you will complete a short quiz covering the information from both the in-person and virtual presentations. Please reach out to myself at rkruger@ctortho.com or Jen at jcharduli@ctortho.com with any questions.